Thank you for having us, and we're excited to be able to speak with you all and hear your questions and engage in some dialogue about this topic that is a defining moment for our country and for us in our lives. So the focus of our presentation today is to give a little bit of context around what we are seeing in terms of epidemiological trends globally in DC, in the greater DC area, and then to talk through a little bit of the implications for provider systems. As you all can imagine, Gretchen and I have been living and breathing this daily, like Dr. Jones and several of you on the line. So we're also happy to take a broader set of questions as they relate to healthcare, as it's relevant to folks. Next slide, please. I think we already had intros done. So before I dive into a few things, just to make sure that we're all aligned on, first of all, I just want to say that, everything we say today will be off the record so that we can just be more direct and kind of share a little bit of the anecdotes of what we're seeing and working on the ground. Like all of you, our priority at McKinsey is solving the humanitarian challenge in front of us. We do that in concert with a lot of our clients. We do that directly through several of us in our teams who provide patient care. And then today's discussion is really a narrow goal, which is to focus on the discussion on some of the data we're seeing and insights we're seeing. There are a whole other set of perspectives that we have available to you on the websites listed here, or feel free to be in touch afterwards if there are particular questions or topics that you're interested in hearing or learning about. So next slide, please. We thought we'd start by just grounding this group in a little bit of the data, which I think we are all inundated with on an hourly basis, if not daily, but stepping back and looking at some of the takeaways from all of the information out there, I think a few things that are important for us to just be grounded on. The first is, as you all know, the share of cases in the US, if you look at the bottom row, has dramatically increased as the pandemic has played out in the last several weeks, with the US now counting approximately 40% of the new reported cases globally, and Europe counting in the 46% range of new reported cases globally. Obviously, the numbers are huge. Obviously, there's also an interaction with the level of testing that any geography can and is able to do. So the numbers that we are seeing there is some interaction there, but I think we all know that the pandemic has hit many of our geographies across the country in massive ways, and we're seeing heroic efforts taken across industries to actually address this. This is truly a pandemic, so there are over 180 countries or territories where we see local transmission, great evidence of local transmission, and we are reaching globally 2 million confirmed cases, and again, likely due to the inability for us to actually test accurately, potentially a lot more than that. And then we are nearing 120,000 deaths that have been recorded. Again, as many of you might be aware, we are dealing with a true data issue, as we're also dealing with fighting this pandemic with variable reporting on deaths. Even some geographies actually require confirmed tests before they report a COVID death. Others are shifting to others require symptomatic. Just kind of like recording symptoms. And I think there's a change as the pandemic plays out in geographies for how they actually do that. So the numbers are the numbers, but I think we also have to take the numbers with a grain of salt for what we truly believe the impact of this pandemic to be. Next slide, please. So this just gives you a visual for what we see playing out globally, right? And I think we all know the fact that the virus has spread worldwide, and despite variable pandemic control efforts in various geographies, we are largely seeing a positive upwards propagation trend in every geography right now except China. I think that some of our Asian geographies are now starting to battle second and third waves of infection, largely due to travel-related new entry points of infection. And we are collectively, as a world, learning, about the virus's behavior, of which there is still a lot that is unknown, to be perfectly frank, including major questions around transmissibility, asymptomatic transmission, and even immunogenicity. And then we're also learning daily and hourly about which measures that are non-pharmaceutical actually work and how well they work, and what bundles of interventions need to be taken in order for us to actually see sustained effect other than a blunt lockdown. So we have early experiments now in Europe, including, for example, Australia, of folks actually pulling back on some of the restrictions, Germany and others. And I think on again, an hourly basis, folks are tracking these things to understand how they might start to apply to our own economy and our own sub-geographies as we think about eventually a return to work from more of an epidemic response or outbreak response. Next slide, please. As we look at how this is played out in the DC metro area, this slide kind of provides one visual of how we've looked at this. And what you see here is the kind of the bottom line, the 9,000 cases, is the curve for the DC metro population. The top three lines are the curves, the curves for Wuhan, Lombardy, and Daegu, South Korea, as they apply to, if we apply this to the DC population. And you'll see that so far we have trended directionally to the shape of the epidemic in these other geographies, but we've actually been a bit lower than if we just looked at how the story played out in these other geographies and applied them to the DC metro area. So I think, some positive news here to take away from all of the measures that you and others in this region have taken to control this epidemic, and some real questions about what lies ahead, right? But I think if we look at the next slide, we also start to see, if you're able to shift to the next slide, yep. We also are starting to see a relative plateauing in the cases on this logarithmic scale on this chart. Across, certainly for DC, but also across multiple other geographies. The caveat here obviously is that this is a total reported cases, so not adjusted for population, but it gives us a sense of the shape again of the epidemic as it plays out.
Yeah, and as that translates into potential healthcare capacity, again, this is total cases, but if you look at just the available beds in these markets against the confirmed cases to date, the DC metro area is in a relatively strong position. Obviously, we've all seen in the press what's been happening in New York, but they are actually about 4 times as pressured as the DC metro area in terms of cases per available hospital beds should they be needed. The only place on this chart that's actually in a better position is Southern California in terms of just relative bed availability. That said, obviously all patients don't need to be hospitalized, and what we're seeing across the country is that providers have rightly stood down elective procedures to make both capacity but also frankly decrease the potential transmission of the disease, which has real implications for providers as they think about managing through the near term, as well as their longer term financial health. If we go to the next slide, McKinsey has put out sort of a framing across industries of how to think about the stages of this crisis. So the first, which we're still in right now, is really needing to resolve the immediate challenges. For healthcare systems, this is largely standing up sort of nerve centers to understand how the data is evolving on a daily basis, how capacity is evolving, staff infections and the like. Then thinking about resiliency. For health systems, not only is there a change in patient volume, as I alluded to, but there's obviously a desire to keep all staff on payroll and therefore needing to meet those near-term financial obligations, which, depending on system size and frankly ingoing financial position, can put real strain on the system's ability to operate through the near term. Some of that has been improved by payouts from the CARES Act. About $30 billion was distributed last week across the country, and we expect a few more tranches of that. But depending on health system's starting position that may or may not have been enough or will be enough to help manage through the near term. The third piece is really then around returning to clinical norms. And even though in some ways that feels very far off, health systems are really starting to think about that now, how to get patients back in, how to think about the appropriate prioritization of cases. And then the last piece is a real recognition, and again, this is true across industries, that things aren't going to all return to normal. There is a bit of a reforming of the system and a reimagining of what needs to happen. In China, for example, although they are now on their 4th week of in sort of relaxed social distancing, the foot traffic in retail stores is significantly down. The increase of online shopping remains up, and you actually see the same trends holding true in healthcare, which we'll speak about a bit more. So if we could go to the next page, a couple of things, providers are having to address sort of across these dimensions. I mentioned sort of the near term needing to just track what is the cases in the community, what are we seeing in our EDs, what's our testing rate per 1,000 populations, how is our staff doing, and then preparing to be ready to address a surge if and when it comes. And to us, this is really a 3-legged stool across the next elements here of making sure you have enough beds, but actually we're finding even more importantly across the country that you have enough of the right staff to be able to treat patients if they come in. And then obviously the supplies to treat them as well. What I think a lot of folks focused on in the beginning was, can we increase the critical care capacity in particular, which from a bed perspective has its challenges, but is actually relatively simple versus making sure we have the right critical care nurses as well as physicians or advanced practice providers who are trained up and ready to go, and that we have the right PPE equipment, frankly, and of course, in some instances, ventilators to be able to care for those patients. The other elements on here are a bit moving into the longer term, thinking about how to change the care delivery model and clinical model. Looking forward, as providers are trying to think about how to reopen, this really gets to universal masking of staff and potentially patients. We're seeing a lot more around the prevalence of asymptomatic cases. There was an interesting New England Journal of Medicine article, I believe 2 days ago, about women in New York who were tested, who had come in for healthy deliveries of babies, and about 15% of them were actually tested positive despite being asymptomatic. And so a real recognition that we can't just have folks walking back in to places like healthcare settings where they're in relatively close contact and run the risk of disease transfer. And that's a real change in terms of clinical model and care protocols. The communication piece on here is also key. We can talk a bit about communication to staff, and obviously what they're dealing with is significantly more intense than they face on a daily basis. Although obviously there are high acuity patients on a regular basis, the consistency with which this is the case, obviously with COVID, but even for non-COVID and things like the emergency room, is pretty significant in causing obviously near-term distress, but also potential for longer-term burnout, and really focusing on workforce resiliency as a priority that we're seeing, not only for health systems, but for states and the federal government to help address at large. Also, communication with patients. I mentioned the sort of consumer trepidation to come back into the healthcare system as you communicate changes in protocols as well as the relative safety and what is changing in terms of availability of patient care is at a pace, frankly, that is faster and more iterative than it is for health systems on a daily basis. Along with care model changes, there's been a real great shift to virtual health for things that can be, which is accelerating a shift that was already happening in the healthcare industry, and providers are needing to adapt relatively quickly, all while through the backdrop, as we discussed, of ensuring financial resilience and near-term cash flows, as well as working with the government on relief through things like the CARES Act, but as well as local market collaboration. In particular in areas that are harder hit, like New York and New Orleans, we've seen real market-based solutions and resource sharing in a way that is relatively unprecedented in the healthcare industry. If we could go to the next slide, just a picture of potential financial play out for health systems. Nadia, if you could go to the next slide, please.
Are you able to see
that? Yep, yes, it's moved, thank you. This is obviously illustrative, and the actual impact financially on health systems will vary quite a bit depending on the starting position. But there was obviously a sort of steady state volume and financial position prior to COVID. And as I mentioned, many health systems have stood down their elective procedures. In a lot of instances, this is in higher reimbursing commercial covered patients. And the patients that they are seeing obviously are quite ill and quite complex. A lot of Medicare covered lives, which just from a financial contribution margin perspective for providers is not as rich as the volume that has been foregone. Not to mention, in most instances, including in the DC metro area, the capacity that is currently sitting idle is leaps and bounds beyond what it would be on a normal basis, with the underlying cost structure continuing. And that has caused a real dip in financials, and frankly, one that even with some restart, we expect to continue. I think there's been some interesting dynamics here as well, where we've seen not only the elective hit, but across the board, a decrease in emergent volume as well. Some of this is not unexpected. For example, we see across the country anywhere from a 50 to 80% decrease in motor vehicle incidents, just given the decrease in travel that folks are undertaking, which on one hand is great, but financially for healthcare systems that often can make a lot of money off of high acuity trauma patients is actually an additional hurt from a financial perspective. Similarly, we're seeing an interesting dip in emergent cardiac volume. Some attribute it to decreased stress, decreased activity, but again, all of this playing into lower volumes and lower financial picture for health systems. The thing is, as you think about restarting, we expect that there may be some pent-up demand, and so there may be a bit of this bump that we see here on the volume recovery, moving to stabilization on the right, actually at a higher level, but unclear how this will shake out based on consumer sentiment, as I mentioned. If you go to the next page, we actually have been doing some consumer surveys, and while this doesn't necessarily get to emergent volume or high-end elective cases, what you can see here is the respondent level in white of consumers who have canceled appointments. And I'm sure we're all in this. I've canceled a dentist appointment, pediatric appointments. But what's interesting is you see then the percent in blue of those respondents who actually have an intent to reschedule. And you'll see that there's a lower level of those in all cases. It varies. But so not only do we have this time period where these cases have not occurred within providers, we actually don't expect that the bump up of pent-up demand will be as high as it otherwise would be if all of the volume re-entered the system. And we believe that the psychological barrier of consumers returning is one that we will all need to work through, back to the comments earlier around proving safety and helping them understand where they should be going for care and the likelihood that they may or may not be exposed to COVID. Not only will this have public health implications if folks aren't coming back in for their routine colonoscopies, mammographies, things that cannot be done virtually, but it also has impact as well on the bottom line for providers. So then just one final page as providers start to think about moving to the new normal of what this might look like even post return of volume. I mentioned really increased telehealth adoption. In some ways, this is great and just an accelerant of a trend that was already happening for increased convenience. The second piece that may actually need to change in terms of operations is in the bottom left. Folks have gotten used to things now like drive-through testing or more rapid testing that could become more permanent as well. On the workforce front, there's the resilience piece that I mentioned, but also there's been some flexing in scopes of practice, team-based models that may be something that are actually not only cost-effective, but more effective for patient care that could be explored and put in place over the longer term. And then we're seeing across industries that all organizations are actually more agile in this time. I think for some, it may feel less in control as decision-making, it may be a bit too off the cuff or based on not enough of a fact base. But there are many positives about the pace at which things are occurring that health systems are looking to embed going forward. And then always keeping an eye to the elements on the right in terms of just the macroeconomic environment. As employment shifts, so does commercial coverage, which, as we mentioned earlier, is a very sensitive thing for provider economics, and then the consumer sentiment and really how to try and boost that. So I'll pause there. I hope that gives you a picture of sort of how we're seeing this play out across the country, and I'll turn it over to Dr. Jones.
Thank you, Gretchen. Can you hear me now?
Yes.
There we go. All right. Good morning, everyone. Certainly appreciate the opportunity to share with you what's going on here at Inova. My comments will be relatively brief because I think there's an interest in a number of questions. I would start with describing, as we saw COVID coming forward, even before it was named anything other than, quote, a novel or new coronavirus. At the time, it seemed a distant thing. Out of an abundance of caution, we started planning even back in mid-January, which now seems years ago, of course. And that at the time, I remember even teasing of, I hope I have to explain to the board how we did all this stuff in anticipation and then nothing happened. And that was the hope, but we couldn't have hope be a strategy, as many have phrased. So we had a task force put together back in late January, began doing preparation. One is just understanding the disease, and largely COVID, now that it's called COVID-19, largely COVID is similar to other respiratory illnesses that we treat every single day of the year in both in the ambulatory area, but when severe, even in the intensive care units. So every system, including ours, has lots of expertise in that. There are some nuances to COVID clinically that we've learned a lot over the last few weeks and months, including our own experience at Inova, that have allowed us to be better at taking care of it, even then in the early days. And the nuances are small, but they're small clinical differences in critically ill patients make a huge difference, and sometimes a life-saving difference. We also stocked up, it was mentioned, PPE, personal protective equipment. We stocked up on that. One is that we knew that eventually we would need some of it. Others, we knew that we probably were overstocked. And thank goodness we have, because I have a personal commitment, as I think most people in my position would have, to protecting our own people. When we have healthcare workers who go into harm's way with an infectious disease, we do everything possible we can to protect them, knowing that you can never protect 100%, but the closest we can come, the better. And as an example, we've built or transitioned from routine hospital rooms or intensive care unit rooms, 213 underway. We're at about 200 of those right now. And they're negative pressure rooms so that the virus gets pulled out into a filter as opposed to going, frankly, through the doors and out into the hallways. And 213 is more than I could have ever imagined in my career that we would have wanted to have. And that's in addition to the fewer than that we had before we started. Again, all to protect our own team members, but also to protect the patients that we have a responsibility for, of course. And I'll come back to that. So our initial focus was on all the clinical. At this point, as has been mentioned here, it does become a significant financial challenge to every single hospital and health system in the country. There was a headline just this morning that Mayo Clinic has I think it was $1.4 billion impact on the organization. And so although we and others are very strong coming into this, no health system can sit back and hope that that's going to just go away on its own. We fortunately have seen some impact from the CARES Act, but it is not even a dent in what the financial impact of health systems will be. So we do now start turning some of our attention to that, because we've been so focused on the clinical care and assuring the protection of our patients. What I will tell you is that it's been inspirational what we've seen our teams come together and do. That as frightening as a new thing is, that's just human nature, that something new that can be dangerous is more frightening than the things we've known for a long time that can also be frightening. But now our teams are developing a comfort with it to the degree that it's kind of the business that we're in right now is largely taking care of COVID-19 patients and only critically ill non-COVID patients. And that presents the challenges that you just heard there, of course. But our hospitals actually have plenty of capacity. We see headlines where everybody's worried about the number of quote beds. We're not short on beds. No one's really probably short on beds. They're short of ability to provide care for the patients. And certainly the tragedy that we see, especially in New York, but some other cities now being equally challenged. It's not that, as we often say, it's not a lack of flat spaces to put patients on. It's a limitation on the resources, including medications, PPE, and of course the expertise to provide care. It was mentioned earlier that decision-making has escalated significantly and in a positive way. It's humbling to see if someone in my position simply gets out of the way of really smart people who know what to do and can get together quickly and make decisions. The extraordinary consistency of those positive decisions. It also means that we are now training people who previously were physical therapists or working in cardiac rehab and other areas that don't have any work at all to do right now because they've been discontinued, to learn to do and assist in the care of more critical patients or in triaging or other things that we still have an increased need to do. And even many of our operating room nurses, for example, many of whom have a critical care background, they're helping now in intensive care settings and other critical settings so that our workforce has transitioned significantly. And across the board, people have pulled together and say, I got into this to take care of patients. I will learn something new if necessary to help take care of patients. And I hope that this entire community is proud of seeing how much that happened. I will tell you that this is hard on our team members. The outreach from the community has been deeply gratifying. We were just talking before this call, Ryan Zimmerman and his wife sent meals to the nurses and doctors and everyone, respiratory therapists working in one of those units where we're taking care of several dozen COVID-19 patients. And it was gratifying that they simply having dinner and knowing that someone appreciated them meant a lot. So the outreach from the community has been great. Many of you, even on this call, your companies have brought forward additional PPE to protect our team members. Very, very appreciated because the supply chain is deeply stressed right now. But even the notes and expressions, people have come and put chalk drawings on the sidewalk, which we want to caution to continue to focus on social distancing at this point. So we don't want a crowd of people outside the hospital doing that by any stretch of the imagination. But the outreach from the community is very appreciated, including we've seen some significant financial donations to recognize the impact that this has had from a business standpoint. And the last comment I would make, and then welcome any questions, of course, is that when this all started and we began social distancing, we all, including myself, said, don't come to the emergency room with everything that's going on right now, because we suddenly have a flurry of activity there and we want to have people not gathering and infecting other people. For probably the first time in my career, people listened to the clinical advice to the degree that people have learned to stay away from healthcare, but actually, as was alluded to, unfortunately are staying away too much. And so we do see people who have chest pain or symptoms of stroke waiting longer than they should to come get care. And I talked to a colleague from within the state earlier this morning that her hospital was full of patients, not COVID-19 patients, because they have fewer downstate than we do, but was full of patients who had chronic diseases that unfortunately had exacerbated because they waited too long to get care. And so now they're in the hospital, critically ill from the standard diseases that they were carrying all along. And so we certainly want the community to recognize if you have real medical needs, we still want to make sure we take care of those needs. We don't want them to get worse. And we don't want you to be afraid of the hospital. Is that someone said, well, the hospital is the most dangerous place. Well, I have nurses now on an almost daily basis say they feel more comfortable in the hospital because we know how to protect and prevent infection in the hospital. It's what we do all year long. So don't be afraid of the hospital. Don't come just for grins. But if you have serious conditions, definitely contact your physician to go to that office if appropriate, or a distance health visit are appropriate. But also, if you have serious conditions, don't sit home and get ill because you're afraid of COVID. Be afraid of the serious conditions that you have and make sure that we get care for them as well. And I would welcome the ability to answer any questions that anyone has.
Thank you, Dr. Jones, and thanks to Dr. Kumar and Gretchen for your remarks as well. We'll open it up for questions at this time. Feel free to use the chat box to submit questions. First question for Inova. There was a mention of workforce resilience in Ryan Zimmerman's donation. Are there further ways that organizations, community, and businesses can provide support to first responders and the Inova staff?
The things we talked about here have been the primary things. We took, for example, a leadership group about a week and a half ago, and I asked for 45 minutes of their time, and I started out by saying, I recognize you're all focused on something else other than yourselves, but we want you to know that you have to be your best self if you're going to be able to provide the best care for the patients. And it was interesting, people appreciated the simple recognition. So I think that we will do everything we can to support our team members. If there are other suggestions that come forward from the community, but the outpouring of appreciation and then even offers of, if there's behavioral health opportunities available, we certainly would welcome those. We do have a link on the Inova.org website with a how can I help button and a number of places there that I would encourage all of you to browse and see if there's something there that you think that you can contribute.
Thanks, Dr. Jones. Now that we're in the midst of the pandemic, what's your biggest challenge going forward?
You know, our biggest challenge, every healthcare system is going to be significantly challenged by what was described during the presentation, is that the clinical care continues to amaze me in the skill and expertise. And I want to slide off to the side there. You know, for example, we had started tiered huddles to where all the way to the CEO, we bring forth safety issues. We had started those several months ago. And at this point on that happens at 1 o'clock every day, and barring that I have a conflict that I can't get out of, I'm on that as well. That we continue to focus on the basics, is that just the simple things, infection prevention, assuring that people have their supplies for the routine care. We make sure we don't take our eyes off that. We now have to face the fact that almost all of our work that is the significant reimbursement in a health system, surgery, procedures, imaging, the things that have all stopped, that's what's all stopped right now. So every health system in the country is facing an impact. For Inova, it's clear it's going to be in the hundreds of millions of dollars, and the CARES Act funding is going to be a tiny, tiny portion of that. So we're being responsible. You know, we take very seriously the fact that we have to be here and be successful to assure care for the communities here that we live in, and we will do everything towards assuring that we can provide that care. So that's the challenge before us right now.
Thanks, Dr. Jones. Another question, are you seeing an uptake in telehealth services, and how is technology helping you? How might you use technology in the aftermath of this pandemic?
Gretchen had mentioned how every system has gotten better, quicker, and more efficient at making decisions. And this is an example where I, even before I came to Inova, spent the last 5 years trying to build virtual visits as part of the care model. I think there's a huge opportunity for it. For example, here in DC, the way I look at it is, unlike in other geographies where they think patients hundreds of miles away can access your care, I'm looking at it here. Up until 4 or 5 weeks ago, people would take 45 minutes to go 2 or 3 miles on the Beltway sometimes to get care. So I saw that as a real opportunity for us. But we were seeing about 100 visits a day at the time, which is paltry compared to the number of visits overall. In a matter of about a week, we went from 100 to well over 2,000 or 3,000, I think at this point, visits a day. So it fast forwarded, because of faster decision making, fast forwarded us becoming a better health system quickly.
That's great, thank you. Are you opening up your hospital system to cover for breakouts in the DMV, and how are you working across state, for instance, Prince George's County?
So we have plenty of capacity in our hospitals right now, and we welcome all patients. We've had in unfortunate situations, even we've had patients who were from New York City that were having difficulty apparently getting adequate care there because of the things that we've all seen in the news. And they drove here and got care at Inova. Now, we don't like the idea that people who have COVID are out driving anywhere. So that's unfortunate that was required, but you know, we are here to provide care for patients. And so we don't turn down any care for patients. Again, I was on a call with CEOs the Virginia CEOs at 8 o'clock this morning working on how we can work together on a number of things. And even, my counterparts in the district, Ken Salmon and I have spoken multiple times, sharing ideas on how we get prepared. One of my favorite stories, Kurt Newman from Children's National, I called up one Saturday morning because there was a specific piece of high complexity equipment that we were in the danger of not having enough of because some quick rise in need for that. So it's Saturday morning. And I called Kurt because I thought if they're not doing heart surgery at Children's National because of the same reasons that we've slowed down heart surgery at Inova, that they may well have some of that equipment that they'd be willing to use. And so I called Kurt. He said, let me look into it. In less than an hour, his person was putting the equipment in his trunk to come and meet our person at Inova. And that was, able to be used that afternoon. And at no point did the two CEOs say, well, this is my stuff. It was really a matter of, we have patients to get taken care of. And it was exactly how healthcare ought to work. And I think that Gretchen mentioned earlier, that's probably happening elsewhere.
Thank you, Dr. Jones. A question for Gretchen. Gretchen, you mentioned increased utilization of advanced practice providers. How do you envision that utilization changing and increasing in the future once we get to the new normal in healthcare?
Yeah, I would love Dr. Jones's direct experience too, but what we're seeing particularly in areas where there has been a greater patient surge is not only some cross-training of staff, so bringing over CRNAs, for example, the certified nurse anesthetists from the ORs who are used to running the anesthesia machines to work in the ICU setting for vents, but also playing at a higher level of license for some surgical physician assistants as well as nurse practitioners. And I think different health systems had done this differently previously, but the proof will be in looking at outcomes. But I think what we've heard anecdotally from systems is it is working, and it is a better team-based model that folks will be looking to sustain over time. And the reality is it is also slightly more cost-effective. And so certainly for some of those clinical areas that are more employed usually in terms of hospitalists and nurse practitioners that are employed at the facility level, we believe we will see a shift to using more of those integrated teams than had happened in the past. I think it's another example of where things were already starting to move, like virtual health, and this is one of the likely positive outcomes as a result of the crisis.
Yeah, I would comment on that. I have a strong bias on this. One is, I believe passionately that we provide care in teams. We lead in teams and we provide care in teams. And that ties exactly to what Gretchen was describing there. And we're seeing that, especially in our intensive care units now, where you can't multiply intensive care unit nurses overnight. But you've got individuals here who are extremely qualified, extremely skilled, and very experienced, who can quickly adopt their skills to that set. So I have a longstanding belief that we should have people do the most that they're totally capable, that they're capable of doing and appropriately trained for doing. And I think this will hopefully help, just like virtual visits, fast forward us to where we truly work as a team with those highly skilled individuals.
Great, thank you both. I have a question for Dr. Kumar. If you have a view on the integrity of the data being released by China, and can you rely on it to run our own models?
This is a popular question, I have to say. So I obviously can't personally comment on the integrity of the data from China. I think there are several questions being raised about it. I think that it has been reported that we actually have several agencies from our government over actually in China looking at triangulating some of the data that we are seeing there. And I think we also have known issues around how they actually counted cases in their reporting that we need to actually adjust, for here in terms of how we are counting cases and deaths in our own reporting. So I think that is the short answer. I think if I step back on the whole data issue, the fact is that we have actually a very small N of countries and geographies that we can actually use when we're looking at population-wide data so far. So this really is a kind of an issue of, even though China was earliest in the reporting because of the disease origination, I think the more data points, the better, and we should not be relying only on a single geography for anything at this point.
Thanks, Dr. Kumar. Another question. Dr. Kumar mentioned that we're still learning about immunity and transferability, even after recovery, and about potential vaccines or cures. Can any of the speakers offer their best guess as to when we might see widespread COVID-19 antibody testing? Any additional insights on immunity, transferability, and cures?
I guess
go ahead, yeah.
Yeah, well, as a physician, I'll at least start. I'm a cancer surgeon, so I'm not an expert in epidemiology by any stretch, but I think that it's important to recognize that the limitations on testing have been significant in this country and continue to be. And so I think a lot of these answers will be determined on how quickly we can get not only diagnostic testing at the moment, how soon we can get immunity testing, and then determine, does that immunity testing really confirm that you don't have that you can't get COVID again, or that you're not contagious yourself. There's a lot of unknowns still in there. So these things, science doesn't happen quickly, and if it's rushed too much, then it's not valid. You know, some of the troubles with point of care testing, meaning the immediate test right now, are based on you have to get to where you can get valid results, because getting a quick result is not the goal. Getting a quick, accurate result is the real key. So there's a lot of things that need to be learned from a scientific basis, which I think are going to be measured in months, not weeks.
I could not agree more. I think that is a huge issue of us trying to make guesses right now on a data set that is, weeks old, right, in many cases with few data points. And some of that is you have to take the evidence that you have and sort of directionally make some bets. But I think a lot of the questions you're asking actually need to be answered in the following months to weeks, and need to be answered in parallel. So I think and I think they're actually different questions, right? So if I just take immunity, for example, we need longitudinal studies of patients who we know have been infected by the virus, and we need to study both viral load as well as antibody response over time. We have early data on that from a few countries that in some cases is, directionally telling us some very early stage things, but I don't think we have anywhere near the level of data that we need to actually make accurate predictions about this. There are also data points that are frankly confusing. If you look at the CDC Korea report that came out a couple of days ago around patients who initially tested showed actually a positive test for virus and then negative and then positive again. And all of these things, by the way, are confounded by sample collection, right? So we don't know if this is because it's actually a true biological issue or whether it's a sample collection issue. So we need longitudinal studies to understand immunogenicity. Secondly, antibody testing. As you all know, the FDA has an EUA in place, an emergency use authorization in place for antibody tests. And I think there is a big question about testing the hundreds, I think now, of tests that are out there. So actually testing the tests to figure out which ones are even accurate and meet thresholds of usability for us to be confident in the data going forward. And several states and countries are actually looking at doing that in various ways, as well as, frankly, some institutions developing their own antibody tests. I think the cures question is the third one, and I would divide that into vaccines and therapeutics. There are over 100 candidates in each category, I believe now, or certainly over 100 vaccines. I think roughly, maybe a little less than 100 therapeutic candidates right now that are in various stages of development. And I think those are obviously the world's eyes are on all of those. Our sense is that for any vaccine, we're trying to compress a timeline that usually takes, several years, right, into what I think most folks would say is in the 12 to 24 month range to develop. And therapeutics, possibly in a similar range, but TBD, because we're really looking at screening a ton of compounds for efficacy, and we don't have great leads as yet.
Thanks, Dr. Kumar. One of my impressions of many organizations is that the drive to optimize efficiency means that we have very little resilience or reserve capacity. Do you see that balance changing in the future? In other words, will we plan more intentionally for that reserve capacity?
I don't know if we're talking, we mean reserve capacity as far as medical capacity. We've got that reserve capacity currently, at least. Obviously in New York, that's a very different story, but we've got that. Our focus on assuring the health and welfare of our team members certainly didn't start with COVID coming up, and it remains resolute of, we will do everything we can to assure that they're safe both from COVID, but also to assure that they've got resiliency tools in place. I certainly am not the expert on those specific tools, but that's a huge focus of us as an organization.
Yeah, and I would just say from our interactions at the state and federal level too, this is very much on the minds. Obviously, we've seen in the press around, whether it's an office for pandemic preparedness, but making sure that there is the systems in place to allow some of the collaboration more seamlessly that Dr. Jones was alluding to within or across markets is really important. And I think a recognition that it's not just the potential of a pandemic like what we've seen with COVID-19, which obviously has deep respiratory complications, requires a lot of critical care capacity. There may be other flavors that require greater outpatient care or potentially greater virtual care that all needs to be built into the system and is to a certain extent either at a regional, state, or national level. And I expect coming out of this, the dialogue will be much greater in terms of how to tap into the reserve capacity that does exist within each health system in a more regular basis.
Thank you, Gretchen. Do you anticipate health providers and insurers partnering to creatively and proactively create new incentives to expedite a financial rebound?
I would ask the McKinsey team to answer first. I've got a couple of thoughts probably.
Sure. I think health insurers have started to do some. There was publication last week around United giving some sort of expedited payments upfront for some patient care, a bit in the form of a loan or just upfront payments. The sort of incentivization for a financial rebound, I can't really comment on, but obviously the delay of necessary care that we were talking about, whether that's exacerbation of chronic conditions or upfront screenings that may find downstream issues, are in the financial and just health interest of both insurers and providers. So we do see even some early conversations, but expect longer term collaboration around patient education and driving for screenings and getting appropriate care to try and prevent longer term issues and ultimately cost pressures for insurers as well.
I think just like we've seen providers working closely together, I mentioned some examples in this discussion, I think it will force us to have to work together a little bit more closely, and that had already been started. It's a journey from a legacy past, I think, but I think that all of us have interest in assuring that the patients get the right care, regardless of our role in it. So I think it'll probably force that, as many of the changes in healthcare are going to be. I hope a little bit tied to this. I hope we don't miss the opportunity here to, for example, with virtual visits. We now have an exemption to where we can do that. That's better care in a number of circumstances and avoids tons of waste and friction in the system of people driving in and sitting in waiting rooms and all the things that, none of us likes that. And so I hope we don't waste the opportunity to learn from this and provide better care, which can probably be less expensive, and not let the regulatory environment or the payer environment harm our ability to do the right thing.
Thank you. We have a few additional questions before we close out this morning. Going forward, it seems critical to quickly identify and isolate cases. How might this work, and how are you thinking about various tracking applications?
The McKinsey team probably has a better idea on that.
Yeah. So I think there's identification of cases, which is separate from tracking, right, and contact tracing. So I think on identification of cases, we've already covered a few topics around the lab testing that might be required to do that, or frankly, even the presumption of positive based on symptoms or protections that you have to put in place to presume some level of transmissibility for asymptomatic patients. You know, in the absence of widespread testing, because at this point in time, we do not have enough tests to test everyone daily who is in a position to be treating, you know, patients, or frankly, in any sort of industry where you have close contact or potential contact with a person or with an item that is very critical, right? Even if we think about distribution centers, for example, or manufacturing facilities for drugs. So that is that. On contact tracing, I think there are multiple ongoing conversations on this. Obviously, the level of tracing that you need depends on where you are in the prevalence of the disease and the pandemic curve, basically. You know, traditionally, departments of public health have relied on really shoe leather epidemiologists and teams to do this. So manual conversations and kind of following up with contacts. And I think this is presenting a whole set of conversations that frankly we don't have good answers on as a society, and I think we will be grappling with over the next few months around the trade-offs between privacy and the potential need to actually be able to do tracing on a much broader scale.
Thanks, Dr. Kumar. What are the key health system requirements needed to reopen our economy, and how do you see that process working?
The key for us right now, we, for example, are continuing to not do certain elective, quote, non-urgent procedures. And there's some nuance in what's really truly able to be held off and not, but we will reach a point where things that we can hold off for a few weeks, we can't hold off without potential harm to patients. So we are very thoughtfully and working with other of our colleagues in other systems to figure out what can we turn on as quickly as possible and as appropriately as possible, both for the patient care and because, again, this is a catastrophic financial impact on the health systems. The key things that I believe have to be in place are adequate access to testing, enough personal protective equipment, and enough medications to assure that we can provide care for the patients appropriately and also protect all of our team members appropriately. We are getting closer to that. We are not there today.
Yeah, I would agree with that. And I think ultimately the health system capacity is the backstop on this, right? Until we have a vaccine or effective therapeutic, it is the ability for us to treat patients if we see future waves or when we see, I guess, future waves as we potentially relax restrictions on the economy. So all of the elements that Dr. Jones just talked through are important to ensure that we can actually treat patients safely and also treat patients of all walks of life safely, not just COVID patients. I do think also in addition that we need to think about this in a world where lab testing is widely available and a world in which it is not widely available, and be ready for both worlds.
Okay. Well, that was great, everybody. We're up on coming up on 11 o'clock now, so we want to close out this conversation. I really want to thank our guests today, Dr. Kumar and Gretchen and Dr. Jones. It was a very interesting conversation. Unfortunately, we ran out of time. There's a lot more questions, but hopefully we can get to those in other future conversations. But thank you very much for sharing your insights with us today. No matter what, I think the road ahead is long and bumpy, but as was noted earlier, I think working together, we can get through a lot of these challenges and on the other side come out a lot stronger and better for the experience. This conversation will be posted on our website later this afternoon. So if anybody wants to go back and pick up anything, that'll be available. Again, next week, we'll have Senator Warren and Senator Van Hollen with us to talk about additional efforts in Congress to address these issues. And with that, again, I just want to thank everyone for participating and have a good day and stay safe. All right. Thank you.
Thank you. Bye-bye.
Thank you.